Okay, so this is my first case. So anybody want to chat in or shout out what you think about this? This patient was a younger woman. Any guesses? So this was the T2. We can see that there's this large cystic lesion in the center of the liver. This is the venous phase. Okay, so Justin is guessing an MCN, and Gitanjali is saying a mesenchymal hamartoma. Good. So that's basically our main differential here, which would be, is this a cyst or like a cystic hamartoma, or is this a mucinous cystic neoplasm of the liver? And the clues here are that it was, as I told you, it was a younger middle-aged female. So that will be one of the clues. And then the other big clue is that there are these little cystic locules along the edge of the lesion. For example, here. And hamartomas usually don't have these cystic locules like this. In this case, the cystic locules actually had some dark signal intensity within them. So we thought that there was probably hemorrhage in those cystic locules. And there was kind of enhancement along the edge of it. I can show you these subtractions. So we did think that probably there was some enhancement along the edge of these cystic locules because they were mostly dark on the T1 post contrast. So this was resected. David Fetzer also says, good location for a ciliated duplication cyst. Excellent. So yeah, ciliated foregut duplication cysts, they're usually in segment 4. I've never seen one this big. And I've only actually proposed it theoretically. None of the ones I've called have been resected. So David, do you have any other tips about ciliated duplication cysts? No, he doesn't have any other tips about that. Okay, so in any case, this was resected, and it turned out to be a mucinous cystic neoplasm. And if you did think this was an MCN, do you think that this is a low grade, moderate grade dysplasia, high grade dysplasia, or invasive adenocarcinoma? So Gitanjali says low grade. Exactly. So this looks mostly clean. We don't see a lot of, an enhancing nodularity, true enhancing septations. We just saw those few little locules. And so this came back, and the entire thing just had low-grade dysplasia, and it did not have any invasive adenocarcinoma or high-grade dysplasia. Steve asked, those T1 bright things, the foregut cyst, those are T1 bright, I think, the foregut cysts. Anyone confirm? Yes, Steve. Typically the ciliated foregut duplication cysts, which are in segment 4A of the liver, I think they tend to be T1 bright. But this was this was an MCN. So the patient got it resected, and I will tell you more about MCNs in a little bit, but they went for resection, and they got their left lobe and the cyst removed. And then this is what it looked like post-operatively. There was actually a collection along the hepatectomy bed that we put a drain into. And we were concerned that there was a bile leak here, and we didn't really know what was going on with the bile ducts. So, and another thing that was interesting here is this is the colon. So this bile leak actually was going on for a little while. And then this is the colon, and you can see some wall of the colon is being pulled into the bile leak, and there's some cystic changes in the wall of the colon here. So we did an EVIS scan, and this is the 60-minute EVIS scan. And so you can see that there's a lot going on here. Try to So this is our posterior bile duct. This was the caudate duct. Caudate duct coming into the posterior bile duct there. And we can see that there's probably a leak directly from this right-sided duct into the biloma, with all of this EVIS, hepatobiliary contrast agent, collecting within this biloma. And correct, Steve got it. So there's actually contrast in the colon. So this is hepatobiliary agent, eovist, within the colon. And on the pre-contrast, that was not there. So this biloma had actually tethered and then fistulized with the colon. The other important point is, what are we going to do about this now? So this bile leak has been going on for a couple of months. They had a drain in place, and they also had a ERCP, like a common bile duct stent. And you can see that actually here's the CBD stent, and none of the eovist is going in the CBD stent or into the duodenum. So basically, it's almost like a transection of the right biliary duct that is going into this biloma. There was high biliary output in our drain, and there's also this fistulous communication. So what they're planning to do is go back in and basically resect, kind of debride all of this, and then pull up a jejunal loop and connect it to this right bile duct. But another important factor here is that that's basically the posterior duct. So we wanted to see what was going on with the anterior duct. And you can see here that actually these are segment 8 ducts right here. And they're also potentially going directly into the biloma. So it looks like we didn't see a connection with the posterior or the segment 8 ducts with the posterior duct. So potentially they're going to have to reconnect a piece of jejunum to both the right bile duct as well as these 2 small segment 8 ducts. So it's going to be pretty complicated. We're still working on this case. But IR is actually getting involved. They're going to put in a PTC into this big right bile duct here, so that they can guide the surgeons to seeing exactly where that is. Because once you have all this bile here, it's very difficult to see the anatomy. David Fetzer saying, yeah, this is essentially like a Kasai procedure. So very complex and maybe inevitable because that mucinous cystic neoplasm was so big, but yeah, pretty scary. I'm going to try to show you, and just to show you, let's see if this will load. Sorry, this was the ERCP images, and you can see that basically there's a disruption between the common bile duct, that dilated sort of right posterior duct, and then actually all of this kind of amorphous stuff was the contrast going into the colon. So we thought at the time, at the ERCP, which was done before the MRI, we thought that it was going maybe into the biloma, but after we did the MRI, we realized that it was actually going into the colon. So just a couple of points about mucinous cystic neoplasms. So in 2010, the WHO reclassified biliary cystadenoma into mucinous cystic neoplasm and intraductal papillary neoplasm of the bile duct. So we no longer use that term biliary cystadenoma. The most characteristic features are that they are lined by ovarian stroma, so they'll have a capsule to them, so they'll have a thick capsule, and they'll have true locules and septations. So the locules that you can see here are similar to the case that I showed earlier, and they might even have true enhancing septations, which would be different than a biliary hamartoma. The other thing that biliary cystadenomas have been now reclassified as is intraductal papillary neoplasm of the bile duct, which Gitanjali talked about last time, but that's when you see a dilation of the bile duct with papillary fronds within it. So these usually can be distinguished from each other, although both of them could be a retrospective diagnosis, but IPNB will be much more tubular, but it can have a cystic form. So here's just a couple more examples of MCNs of the liver that from my practice. So you can see it looks very complex here. We've got this T2 bright lesion. It's got these cystic locules within it, multiple different spaces. On the T1 pre-contrast, they've got multiple different shades of gray with a lot of T1 hyperintensity in it from both mucin and hemorrhage. Post-contrast, it's a little bit hard to tell, but on subtraction, you can see that there's true enhancing septations crossing the lesion. And then these are going to be much, much more common in females, just like the pancreatic MCNs. The reason why is that it's thought that a little bit of ovarian stroma is left usually in segment 4 of the liver. Embryologically, it's close to the left ovary, as well as the tail of the pancreas. So the ovary leaves behind a little bit of ovarian stroma in either the left lobe of the liver or in the pancreatic tail. And over a lifetime of hormonal proliferation, it turns into this more symptomatic lesion. That's why it's almost exclusively females and almost exclusively in sort of young to middle age. Here's just one more example of an MCN. So you can see that there's this big T2 bright lesion, but it's got true enhancing septa in it. It's got this mosaic pattern or stained glass pattern. This is typical of mucinous lesions, especially of the ovary. And then on the post-contrast, it has those true enhancing septations. And then here were a couple of trickier cases. So this one looked like, maybe a hamartoma, but it had that nice capsule to it. It was in segment 4 of the liver. This was resected and was an MCN. This one I thought looked very similar, but was also resected and was a biliary hamartoma. The clue here might have been that this was a male and that it was in the right lobe. And just as a comparison, this is what more typical biliary hamartoma looks like. This is what I call pseudoseptation. So these are just kind of like indentations of the adjacent liver right next to it. So we look at kind of a spectrum. This is a hamartoma. These are much, much more common. They're usually multiple. This also turned out to be a hamartoma. So there can be an overlap between a biliary hamartoma and a mucinous cystic neoplasm. But in a middle-aged, especially female, think about an MCN. And then when it has locules and true septations to it, definitely think about an MCN. Although the ones in the liver actually tend to do better than the pancreas ones, and a lot of them just have low-grade dysplasia. There was a chat. So Josie said, do you need to screen the ovarian tissue for a concordant mass? That's a great question. I have never heard that the ovary is also affected by it. I think it's literally like either some pluripotent cells that are left embryologically or maybe just a tiny bit ovarian tissue. I've never heard that they're also associated with ovarian masses. But one thing I have learned is two things I learned. One, we think like for mucinous neoplasms of the pancreas, you can aspirate, like if they do endoscopic aspiration and the CEA is elevated, that's a marker of a mucinous lesion. So we thought that that would be helpful in the liver as well. Like occasionally when we're not sure, is this an MCN or a hamartoma, the surgeons have said like, well, do you think that we could maybe aspirate it and send it for CEA? And so actually 2 cases we had, this is very anecdotal. I couldn't find anything in the literature, but we did send off 2 cases for the CEA. And one, it was a hamartoma and the CEA was actually 15,000. So that to me says, I don't know, at least I couldn't rely upon the CEA in that case. And we were also worried about like, if you aspirate it, you might spread some of the mucinous material. So the CEA wasn't necessarily elevated. And then the other thing that we learned was that say you think that it's a cyst, but you want to get a frozen section on it, and you send off, you're fenestrating it and you're leaving part of the wall there because you think it's a cyst. Frozen section can be very difficult to do on these because the ovarian stroma is patchy. So it won't be completely in the entire wall. So unless they analyze the entire wall, they won't be able to definitely tell you if there's ovarian stroma or not. Nellie said she wants to show a paper on this topic from Cookie on how to differentiate cyst versus cystosarcoma. Great. I'm going to stop sharing my screen. Nellie, are you?
Yeah, I'm here.
Okay. Can you share your screen?
This is a really great topic, and we were like having a, it's just really hard sometimes to differentiate complicated cyst, biliary cyst from mucinous cystic neoplasm. So this is a paper that is in press right now from the Mayo Group and that Cookie shared with us, which is really, I think, really helpful. And the paper describes basically sort of the indentation pattern. So when you have indentations like right here, right, with a septa, these are like cyst. In contrast, if the septations, and this corresponds to some of the cases that you presented, if the septations like go to the margins, like they're within the cyst, then this is a mucinous cystic neoplasm. So this, for example, is a combination. So this is probably 2 adjacent cysts with a sort of a MCN, and this is an MCN, whereas this is a cyst, and cyst.
Cool. Actually, Nellie, that picture reminds me of like how I explain pancreatic MCNs versus serous, because the MCNs have a capsule. they
Yeah.
will have like that very like solid rim, so it'll be round or ovoid, whereas
Yeah, yeah.
this lobulated edge because the capsule won't be lobulated like that.
That's a really great point, and that's exactly what they described with biliary mucinous cyst adenoma versus just like a simple cyst.
Cool. Does Cookie know you're showing this ahead of press?
It's in press,
Okay.
so it's I mean
Yeah.
theoretically public. But
Awesome.
she shared it with our group, and she shared it during HC conference because we've had multiple cases where we just have a very hard time
Yeah,
telling the difference.
we did too, and then that's why there was all this talk about like, well, should we? But my takeaway now is that if there is overlap, if you're not sure, because I do think there are some cases that you're not sure, it's better to bring it up so that they don't just fenestrate it and then have to go back and re-resect that part of the liver, because that makes it much more
Yeah,
complicated.
yeah.
But I was a little disappointed that the CEA was unreliable and that the frozen sections would be too. But yeah, I guess the other silver lining is that they tend to do a lot better. They tend to mostly have low grade dysplasia. Cool.